Hi, my name is Jordan Sidebottom. I am here to talk about neuroprotection of neonates in the NICU and how nursing care can impact outcomes. This is a presentation that is created for students in BSN programs who are going to be future NICU nurses. There are three objectives that I want this presentation to achieve. I want the audience to understand the importance of neuroprotection of premature infants, otherwise known as preemies. Describe three ways nurses can protect preemies from adverse outcomes, and knowledge of the history of neonatal intensive care, and how this impacts current practice. This presentation is going to focus exclusively on extremely premature infants. These are infants that are born less than 28 weeks gestation, and they often weigh less than 2 pounds in weight. It is important to note that the more premature an infant is, the greater risk the infant has of morbidity and mortality. The cutoff for viability in the United States is 23 weeks gestation. These infants have a less than 33% chance of survival and a less than 2% chance of survival without a major morbidity such as cerebral palsy and chronic lung disease. So what is neuroprotection? Put simply, it is the protection of the infant's brain from harm. As you can see in this graphic, a baby who is born at 20 weeks gestation has a much smaller and poorly defined brain than babies who are born at term or 40 weeks gestation. It is important to note that as a premature infant grows, that it is not only in size and definition that the baby needs to grow, but the premature brain has more fragile and tiny blood vessels. And these small blood vessels are impacted by drastic changes in blood flow and oxygen levels. It is important to note that a baby's brain at 35 weeks gestation weighs only 2/3 of what it will weigh at 40 weeks gestation. It's really quite remarkable to think that this rapid growth is going to happen in 5 weeks. As future NICU nurses and even as NICU parents, it can be frustrating because we don't see all this delicious brain growing that's happening. Instead, what staff and NICU parents are seeing is this baby who sleeps 22 hours a day, is learning how to regulate their body temperatures in an open crib, and is learning how to eat. And it can be frustrating because we can't see all this great growth and strides that these babies are making every day. These are the biggest factors that can cause adverse neurological outcomes in premature infants. For this presentation, we are only going to focus on low birth weight and gestational age, but it is important to note that genetic disorders of the infant, the mother, or the father, placental disorders, and maternal factors can all have adverse neurological outcomes on infants. Prematurity is the leading cause of neurological disabilities in childhood, and it is the most common risk factor among this demographic. While creating this presentation, this presenter really found it difficult to do the subject of neurodevelopmental outcomes in premature infants justice without going into great depth. Each one of these slides could easily be a seminar in and of itself, but that is not the point of this presentation. However, the graphic on this slide really does sum up the problems of neurodevelopmental outcomes in premature infants well. On the left side, you have pre-birth cofactors, so anything that happened in utero that would have stressed the baby, that would have restricted the baby's growth in any way. If mom, any maternal factors, placental disorders, genetic disorders. And then in the middle of the graph, you have the predictable caregiving experience or the NICU environment. This is the growth that the premature baby has to do while outside of the uterus before the baby is considered full term and it has that great brain growth that has occurred. And the combination of intrauterine stress and extrauterine stress can cause neurobehavioral organization and cognitive function problems. The American Academy of Pediatrics recommends that infants not be exposed to sound greater than 45 decibels. This is kind of a joke in the NICU world because the average ventilator alarm is 65 decibels or greater. Same with IV pumps. Any feeding pumps that go off, they are louder than 45 decibels. So we do our best in the NICU to keep the environment warm and dark and quiet, but it is often not possible as we need to keep these babies closely monitored on monitors that make noises louder than what they should be exposed to. This is a common list of adverse neurological outcomes for this population. The most common is the intraventricular hemorrhage, otherwise known as IVH. The graph on the right shows the grading system of IVH. Grade 1 is bleeding in the white matter near a ventricle. Grade 2 is bleeding in the ventricle. Grade 3 is bleeding in a ventricle where it's almost completely full, and the grade 4 is a massively enlarged ventricle with bleeding in this brain matter. It is important to note that about 30% of extremely premature infants have IVH, but only 90% of these babies suffer from adverse neurological outcomes in childhood. So that really speaks on this population's ability to heal themselves, and that children are constantly forming neural pathways well into their 20s, and oftentimes bleeding in the brain is not an issue long term. Periventricular leukomalacia, or PVL, occurs when there is great swelling and bleeding in the brain, and then once the body reabsorbs that extra fluid, then on ultrasound or MRI, these little pockets of PVL look like Swiss cheese, where there was great enlargement and swelling that occurred. Periventricular leukomalacia is associated with poor neurological outcomes. These babies are at risk of having hearing or vision loss. Anytime you have enlargement of the ventricles or bleeding in the white matter, you're going to have extra pressure put on different parts of the brain. This can cause pressure on different nerves, and it can cause hearing and vision loss. These infants are also at risk of ototoxic symptoms of common antibiotic use. These babies are also at risk of having learning disabilities and attention deficit disorders later in life. They are also at higher risk of cerebral palsy and even death than infants who were not born premature. So how can nurses protect extremely premature infants from adverse neurological outcomes in the NICU? Well, nurses can wash their hands, keep the baby in a neutral thermal environment, feed the baby appropriate food, incorporate developmental positioning and care, and involve families in caring for these babies. Hand washing is one of the most basic but vital steps that nurses and all caregivers, including parents, should do to protect these babies from harm. Why are extremely premature infants at risk of infection? Babies born at 24 weeks are at 6 months of life at the bottom of this graph. So you can see that the primary lymphoid organ is the liver, that the body has not fully formed or even started forming the bone marrow. The thymus is small, and the baby has poorly formed lymph nodes. So this means that the baby does not have the appropriate number of mature white blood cells to fight off an infection. It is also important to note that these babies have underdeveloped skin at this time, that the skin is the largest organ in the body, and when these babies are born this early, it's like tissue paper. So it's really easy to accidentally bruise, cut, or have any opening of the skin, and that just is a welcome mat to any infection that could occur. How many babies do you think in the United States die in the NICU due to hospital-acquired infections? A shocking 30,000 deaths occur every year of premature infants because of hospital-acquired infections. Okay, so if hand washing is such an important care aspect when working with this population, then why don't all nurses and care providers perform hand hygiene set by their hospitals? One issue is the understaffing of nurses. On average, a nurse washes their hands 100 times during a 12-hour shift. If a nurse has a heavy patient assignment or has more patients to see, it is an expectation that that nurse is going to wash their hands more frequently than 100 times. However, the more patients a nurse has, the higher risk of infection. One of the strongest indicators for hospital acquired infections is job satisfaction. If any care provider feels overworked and underappreciated, then job satisfaction is likely to be poor. It is also important to note that the longer a patient stays in a hospital, the more likely they are to acquire a hospital infection. Another important thing that nurses can do to protect extremely premature infants from poor neurological outcomes is to keep the baby warm. Babies who are born extremely premature have lower levels of body fat, especially brown fat, that helps keep the babies warm and protect them from cold stress. The more premature the baby is, the higher risk there is for hypothermia. And hypothermia in this population is associated with infant death and intraventricular hemorrhage. So in this picture, you can see this extremely low birth weight infant that was likely just recently born. And the care providers in the delivery room put the baby in a what looks like a plastic bag. This helps decrease insensible water loss and helps keep the baby warm once the baby is born. The hat is important too because the head is the largest surface area of the body. So putting a hat on a baby will help keep the baby warm. The idea of keeping premature babies warm is not a new one. This dates back to the late 1880s in France, and Dr. Stephanie Tarnier created the very first incubator. At this time, the country of France had recently lost many soldiers during the French-Prussian War, and there was concern that there was not going to be enough soldiers to fight for the country in future wars. So at this time, premature babies or babies born very small had really no hope for survival. And the country decided that it might be best practice for them to try and find ways to keep these babies from dying so that they would have future soldiers to protect the country. So Dr. Tarnier went to the zoo in Paris and saw an exhibit of exotic bird eggs that were being kept warm in a wooden box with a heat lamp. And he thought if this worked well for exotic eggs, maybe it would work well for humans. So, along with the help of the zookeeper, he created what is now the prototype for the very first isolette. And the picture of this is on the left side of this slide. The framework of the isolette is wood, and the hollow wood had sawdust stuffed down inside for insulation. The baby is laying on a bed of pillows, and above the baby's head is a glass window so that doctors and nurses can keep an eye on the baby and look for signs of cyanosis. And under the baby's bed is a water bath, and with this enclosed structure, the ambient temperature would help keep the baby warm. Now, at the time, the country of France really didn't like this technology, and they refused to believe that this would help keep babies warm when they thought that putting a hot bottle warmer or a pot of boiling water in the crib with a premature baby would do the exact same thing. Poor Dr. Tarnier. He worked so hard to create this isolate, and hospitals in Europe refused to accept this technology. It wasn't until the early 1900s when Dr. Martin Cooney, who was a student of Dr. Tarnier, brought this technology to the United States that people started to notice the importance of it. Between 1903 and 1941, Dr. Cooney set up the show called The Infant Incubators with Living Infants at Coney Island in the Carnival. The other carnival acts included sword swallowing ladies and clowns. This side act ran for 40 summers, and he charged 25 cents for visitors to come and see these small babies in isolettes. It wasn't until the 1950s, when Dr. Cooney had passed away, that hospitals started to acknowledge the importance of the use of isolettes in protecting premature babies from harm. And it was kind of wild to think that babies at this time received better care at a carnival and a sideshow than they would have in hospitals. These two pictures are also from Dr. Cooney's Coney Island exhibit. In the left picture is Dr. Cooney holding a small boy with a nurse who happens to be his wife as they look into a baby in an isolette. On the right are nurses who cared for these premature infants, proudly holding these babies up. Dr. Cooney is recognized for saving thousands of babies' lives during the 40 years that this exhibit ran. Also, during this time, it's important to note that there were round the clock doctors and nurses who provided care for these babies.
That music means it's Friday. It is time for StoryCorps. New York's Coney Island used to be known for sideshows featuring tattooed ladies and sword swallowers. 95 years ago, it was also known for its exhibition of tiny babies. They were premature infants kept alive in incubators that were pioneered by Dr. Martin Cooney. The medical establishment rejected the use of incubators. Dr. Cooney didn't give up, though, and each summer for 40 years he funded his work by setting up exhibitions of his incubator babies. Parents didn't have to pay for the medical care. Many of the children survived. Lucille Horn was one of them. She was born in 1920, and at StoryCorps she told her daughter Barbara how she ended up in an incubator at Coney Island.
My father said I was so tiny he could hold me in his hand. I think I was only about 2 pounds, and I couldn't live on my own. I was too weak to survive.
So the hospital didn't have anything to
No,
offer?
they didn't have any hope for me at all. It was just, you die because you didn't belong in the world. So when I was born, my father was looking for a blanket or a towel to wrap me up, and then somebody said, "Where are you going?" He said, "I'm taking you to the incubator in Coney Island." The doctor said, "There's not a chance in hell that she'll live." He said, "But she's alive now." He hailed a taxi cab and took me to Dr. Cooney's exhibit, and that's where I stayed for about 6 months.
Do you know how your parents knew about the incubators?
They saw the exhibit and their honeymoon. You had to pay to go in, and then the babies would be all lined up.
How do you feel knowing that people paid to see you?
It's strange, but as long as they saw me and I was alive, it was all right. I think it was definitely more of a freak show, something that they ordinarily did not see. But I remember going when I was older to see the babies.
You met Dr. Cooney, right?
Yes, he happened to be there at the time I went in. And I went over and I introduced myself to him. And there was a man standing in front of one of the incubators looking at his baby. And Dr. Cooney went over to him and he tapped him on the shoulder. And he said, "Look at this young lady. She's one of our babies. And that's how your baby's going to grow up." I remember he gave me a hug before I left. You know, there weren't many doctors that would have done anything for me. 94 years later, here I am, all in one piece. And I'm thankful to be here.
That's 95-year-old Lucille Horn with her daughter Barbara for StoryCorps in Long Beach, New York. Dr. Martin Cooney cared for premature infants on Coney Island for 40 years. He died relatively unknown in 1950, shortly after incubators were allowed into most U.S. hospitals. This conversation will be archived in the Library of Congress, and you can hear more on this.
Isn't that an incredible story? In modern day NICUs, we use isolettes as seen in this picture. They are a reliable heat source, and we are able to add humidity to the inside of the isolette to decrease insensible water loss in these babies. We attach a temperature probe to the baby's skin, and we want the baby's body temperature to stay between a certain range. And the isolate on the inside gets hot or cold depending on what the baby needs at that time. The importance of keeping a baby's body temperature between a certain range, it allows an environment where the baby is not burning as many calories to keep their body warm. And because of this, their blood sugars are able to stabilize. They often have a decrease in oxygen requirements, and they are able to slowly gain weight. Another thing that nurses can do to protect these extremely premature infants from adverse outcomes is to feed the baby. The American Academy of Pediatrics recommends that women breastfeed or provide breast milk until the infant is at least 6 months of age. When an extremely premature infant is first born, all nutrition is provided through an intravenous line, and these babies often are provided total parenteral nutrition or TPN. This baby in this picture has an IV in his left hand, but often these babies have umbilical lines placed soon after birth to provide nutrition. It is not until about 24 hours of life that a gastric tube is placed and babies receive what's called trophic feeds, which is a small amount of milk, of either donor milk or breast milk, through the tube. And the importance of this is to help the baby get used to having milk in the belly, but also it helps the baby coordinate gut peristalsis. It's not until about 29 to 30 weeks gestation that babies have the ability to coordinate gut peristalsis. However, it is an important thing for these babies to be able to do to coordinate getting all nutrition through milk. Slowly, the IV is weaned off, and the amount of breast milk or donor milk or formula that the baby receives is increased. The goal is for the baby to receive all nutrition from milk, and this process can take 2 to 3 weeks depending on if the baby tolerates food or not. It's not until around 35 weeks gestation that babies develop the part of the brain that allows them to have a strong suck, swallow, breathe pattern. It can take premature infants up to 40 weeks or their due date, or even past their due date, to develop this part of their brain. This can be a frustrating part of the NICU stay for both NICU staff and NICU parents, as we want these babies to learn how to eat, we want them to learn how to eat quickly, and we want these babies to go home as soon as possible. However, forcing these babies to eat when they do not have a strong suck, swallow, breathe pattern puts them at higher risk of aspirating milk into their lungs. A recent study conducted at Washington University in St. Louis found that premature infants whose diet consisted of at least 50% breast milk had larger brain matter and cortical surface area at term gestation than those patients who received less breast milk. If a mom is not able to provide all the breast milk that a baby needs, there are donor milk banks throughout the country. Women who have large milk supplies are able to donate milk to these milk banks. The milk is pasteurized and then frozen and provided to NICUs throughout the country. What's important to note is that when this milk is pasteurized, that it kills off any bad bacteria or viruses, but it also kills off any antibodies that is important for these babies to build their immune systems. Another important care aspect that nurses can utilize when protecting this population from poor neurological outcomes is the use of developmental positioning. Developmental positioning is the idea of providing flexion for the baby um, so that the baby can get comfortable. In utero, the amniotic fluid would provide an environment where the baby is able to stay in a fetal position, where the head is midline, the nose is in an imaginary line with the belly button. The elbows and the hands are flexed and the hands are by the face, and the knees are brought up towards the belly button. And it has been found that babies, when they are placed in positions like this, that they spend more time in a autonomic state. And this population is so important because it decreases apneic episodes, it decreases bradycardia and desaturations. It also promotes a really deep sleep state in this population. It is estimated that babies at 32 weeks gestation sleep 90 to 95% of the day, and it is expected that babies who are more premature require more deep sleep. When a baby is in a deep sleep, they do more growing and healing. It is important to have the head of the bed up higher, where the head is more elevated, is above the line of the knees, and this helps cause or decrease any cerebral blood flow changes that can happen, especially where the knees are brought up higher than the head, especially like during a diaper change. This can cause a drastic change in cerebral blood flow and might put the baby at higher risk of an intraventricular hemorrhage. This graphic is of the Infant Positioning Assessment Tool, otherwise known as IPAT. And this is a tool that helps measure developmental positioning, and a desirable score is between 10 and 12. So you can see that when a baby has the hands flexed towards the face, the elbows are brought in midline, the head is in line with the belly button, and the knees are flexed towards the chest, that you're going to have a higher score than if the baby is not in a flexed position. These are two examples of extremely premature infants in poor developmental positionings. The first one on the left is of a baby whose head is turned completely to the side and the nose is not in line with the belly button. Both arms are not flexed and brought towards the face, and there is no flexion of the knees and the hips noted. On the right, same thing, where the baby has full access to his hands. He's not able to keep them in a flexed state towards his face. His head is in line somewhat with his belly button, but he does not have anything to brace his legs up against, so he's not going to keep his knees and hips in a nice flexed state. These are examples of great developmental positioning. The baby on the left is turned on the right side. The nose is in line with the belly button. The hands are brought to the face. There are boundaries placed that keep the elbows in place. The knees are brought up towards the chest. The baby has the boundaries to press the feet up against and keep the baby in a nice flexed state. Same thing of the middle picture, the baby's prone on a developmental positioner. The shoulders are nice and rounded. Even though his head is turned to the side, everything else is brought and flexed and is midline, and the baby looks like he's nice and comfortable. And then same thing on the right. The head is midline with the belly button, the knees are brought in towards the chest, and the hands are by the face. Historically, NICUs had strict visitation hours for families, and the care for these patients were almost completely done by nurses and other members of the care team. Now, the NICUs are involving parents more in the care for these babies, and it helps alleviate separation from parent and child. It is also important to note that babies, when they go home, all the care aspects are to be provided by the parents. And so it is important over time for nurses to teach these parents how to take care of the babies, as the nurses do not come home with the babies. Kangaroo care or skin to skin care is something that either the mother or the father of the baby can provide. During this time, the baby is placed vertically on the parent's chest in between the nipple line, and the parent's chest will get hot or cold depending on what the baby needs. During this time, there are benefits noted for the baby. It increases a deep sleep state. They are more likely to gain weight. they often have a decrease in extra oxygen requirements and it increases bonding with the parent. These little babies are smart and they know who their parents are, and they respond to mom's voice, mom's scent, and mom's heartbeat. Benefit for the mothers include it helps mom make more breast milk. It increases mom's oxytocin and tryptophan, so it's going to help with decreasing any pain that mom is experiencing after delivery, and it's going to help increase bonding with this child. Throughout the country, kangaroo care saves 450,000 premature infant lives worldwide. It has also reduced premature infant mortality by 33%. Kangaroo care is an important aspect of NICU care that parents can provide. However, there are times when a baby is too sick and too fragile for this much stimulation. It can be very stressful to get these babies out of isolates. The babies in this picture is in an isolate under humidity, under phototherapy for treatment for jaundice, is on a ventilator, and is on quite a few IV fluids. It might be too stressful on this day to get this baby out to kangaroo with a mom who's sitting quietly at the bedside. Days like this are very hard on NICU parents and probably much harder than they can verbalize or that NICU staff can comprehend. During this time, many moms report that the best thing that they can do for their baby when they're too fragile to come out in kangaroo care is to pump their breasts. It's something that keeps their hands busy as we ask mom to pump every 3 hours to develop a milk supply for their baby. However, this is also a great time for nurses to educate parents on stress cues that the babies might be displaying, such as the flailing of the hands, the hiccups, an increase in oxygen requirements, a noted increase in apneic episodes, and providing education like this really helps parents understand why we're doing what we're doing for these babies. Kangaroo care originated in Bogota, Colombia in the 1970s by Dr. Edgar Ray. This hospital, the Instituto Materno Infantil, was the largest NICU in the country at the time and delivered over 30,000 babies every year. This hospital noted that the premature infants that were born at this time had a 70% chance of mortality. This was because there was poor access to medical supplies such as isolates, and these premature infants had to share isolates like the babies in this picture. IV fluid bags were rinsed out with soap and water and reused, so infection rates were incredibly high. Dr. Edgar Ray wanted to change this and encouraged mothers of premature infants to hold these babies skin to skin in hopes of stabilizing the body temperature and decreasing the need of isolate sharing. This practice change was implemented to 500 premature infants between 1978 and 1981, and survival rates of this population tripled. This practice was later implemented in all NICUs and is not to be used as a substitute of highly skilled NICUs, but is instead expected to be used and congruent with NICU care. A recent study at Columbia University looked at 264 extremely premature infants who weighed less than 1,800 grams at birth. This study looked at the effects of kangaroo care 20 years after the NICU stay. And this study focused primarily on the neurodevelopmental outcomes of these babies later in life. The studies found that babies who received kangaroo care in the NICU had less school absenteeism, a reduction in hyperactivity, increase in social function, and a decrease in social deviance. In modern day NICUs, parents are now encouraged to read, talk, and sing to babies as long as it does not overstimulate them. Babies are able to hear around 24 to 26 weeks gestation, and talking to the baby can be a great way to bond with the child. Currently, research shows that babies who are exposed to reading and being talked to in the NICU have higher language and cognitive scores at 18 months of age. However, this is a great area of future research as there are no longitudinal random control studies on early exposure to language and neurodevelopmental outcomes past 18 months of age. The major goal of involving parents in care is to ensure that the parents are comfortable providing all cares for the baby at home. It is estimated that 2 out of 5 moms suffer from mental health disparities after premature birth. But I would challenge this and say more like 5 out of 5 moms have mental health issues after giving birth early. It's just that only 2 out of these moms are able to verbalize their feelings. There's also very little research about the effects of premature birth on fathers and whether or not they suffer from PTSD and anxiety and depression. There's also very little research about any other life partner that a mom may have and how premature birth impacts their life. This is a great area of future research in the NICU. It is very important to note that the parent-child bond has 10 times the effect on outcomes than any other care factor in the NICU. It is also important to note that a decrease in parent attachment to child has adverse outcomes for both the parents and the child. If a parent suffers from post-traumatic stress disorder, depression, and anxiety, these premature infants, as they grow into early childhood and even into adulthood, can suffer future behavior and cognitive deficits. So it is really important as a nurse caring for these babies to know that you are not only caring for this child, but it is so important that you care for the entire family. There are barriers to NICU nurses providing developmental care to these babies. One is staff attitude. It is much easier for a nurse to perform a head-to-toe assessment, change the diaper, developmentally position the baby, turn a feeding pump on and feed the baby through a gavage tube, and leave the baby alone to sleep. It takes more time to educate parents, to involve parents in care, and to support the mom with breastfeeding or get the baby out to kangaroo care. There are also times when a baby is too sick and the severity of the patient acuity does not allow room for neurodevelopmental care. The baby in this picture is very ill. Baby's on a ventilator, has a chest tube, is on multiple IV pumps, and there are times when you come into a assignment and this is the acuity of the patient. This baby is going to be exposed to many loud alarms. The lights are going to have to be bright as it is important for the nurse and all care team to really observe the patient's color and work of breathing at all times. It is not appropriate to get this baby out for kangaroo care breastfeeding at this time. There are also times where there are lack of resources such as time, equipment, and supplies that don't support NICU nurses with providing neurodevelopmental care. If a nurse has a heavy patient assignment, that nurse may not have the time to get the baby out and for kangaroo care and to observe parents and make sure that they are safely holding their fragile infant. There are some NICUs that do not have the number of isolettes that are needed. It is not uncommon for these NICUs to take a baby out who's close to transitioning to an open crib, and the nurse will disinfect the isolette and then they'll admit the new baby in the isolette. Thank you for taking the time to watch this presentation. If you have any questions, I will provide my contact information. In the meantime, please fill out the survey on the hyperlink on the slide for an evaluation form. Thank you.